guy or this guy?
No, yeah, the first guy. The other guy also, you know, like everyone's been saying, oh, it's just implementing so much. But listen carefully, and like if you look back at your notes, he's throwing a lot of function. So it is worth processing.
Which is why I said you gotta find out. Yeah,
Yeah, class, but like I go to class now just to like to see what to focus on and then find it elsewhere. Yeah, I'm not looking for this exam and all stuff. Like I'm not doing these slides because they don't have any information on them. Just a picture. I'm saying, but that's just a picture of a spinal. That's polymer now.
There's a couple slides actually just like list things and I'm for sure like
I don't know what way to know. I'm just grabbing straws. But everyone's focused on other things. I'm hoping like everything has like a certain thing that's important for it. Yeah. Each thing has or looking for a thing.
yeah, how was the gym? How was cardio and abs?
Did you do the spinning ones or whatever those are?
Did you do the penguin?
Oh yeah, I did that too.
I used to do the average relax thing.
It's only one set. I only did one set.
You do the average relax?
No, I have a paper. Somebody sent me a paper.
It's very similar, Ron. And you kick it. I'm trying to remember. It was like I used to know it by heart. Now it's like I don't know what the words mean, but I know what this one means. Like punches, bicycle.
Wait, what happened to the muscle fitness?
Oh, I took a break yesterday to do it.
Side. Oh, side punch is the one where you go like this. That's also an average relax. Oh, those are classics.
There's no classics. There's nothing changed here. This is all the regular.
This thing?
Yeah.
What's your favorite?
I like that thing. It feels very functional.
Abs, I skip abs day all the time. I never do abs.
It's not because I have abs. I used to do it. Now
Jason has great abs. Particularly.
I love this. Like, so there's like this one, and then there's
I do that laying down with the weight in between my legs.
Yeah, so there's like you kick it in
Yeah.
everything, and then
I do
there's
that.
also
I do that on
one.
bench.
There's all kinds
What
of
does this
fun
thing do
things.
for you?
Oh, it kills you. I think it works your
obliques.
obliques. Yeah. Obliques! Yeah, you like that shit. It works the obliques. You like do this crazy thing. It kills you. And you do it at the end, like at the end of abdomen, you're dead, and it's like sticking blade, like not the knife blade in you. It kills you.
These are also.
I don't remember what else there is in that. There's the kicking
I do
one.
crunches.
Oh, there's the one where you lower the legs and all that crap, and then you hold it above the ground for a while. You know, or like you go like this, and you like hold like a couple inches off the ground. Pain. Pain.
It looks like that now. I don't do any of that.
Hey.
You should go with Hoodie. Hoodie knows what's Hoodie just can't touch. You get like 12 things. I feel like Hoodie was a real expert.
Plus, I go to the gym.
Yeah.
If I went to the gym a lot and lifted a lot of weights, and I be an expert, I know all the moves there.
Yeah.
Anyone.
Check.
But especially,
If anyone puts in the time, they can.
especially.
I used to do this stuff a lot.
Why you gym?
Why you gym? I was bulky. Yeah. I feel like most of everything.
How is you?
Yeah, I was one of those. I was
And then naturally.
busting the shapes and all that. Yeah, I
can't see the shakes
the shakes and
Shakes?
and then I got more into like actually feeling good. Cause like it's like too like you feel you feel good, but like I don't know, it was just like I felt better getting my heart rate up in other ways than like I don't know. Also that stuff's pretty bad for you. Like, it destroys your kidneys and stuff. Once I was on all those like green creatine and all that stuff. It's not good for you. 3:30 a.m. Bad for your liver.
It's like Black Friday. Now he's waiting for hours. He's still there. And his number was on the line.
I don't know if people do.
They're going even numbers only.
That like whey protein stuff is so
I was going to do one thing.
it's such a
I
good
like that. You made a lot of money that way.
like you learned this year about what protein does. Imagine just like injecting your kidneys with whey protein. A lot of toxic blood stuff. Urea, ammonium, and all that stuff. So we work very hard to get rid of these toxic things in our body, and we pump ourselves full of them. It destroys it. Oh, we making vanilla flavored? Whatever.
Yeah, look. Gotta be somewhere tomorrow, 3:30. You have to get a residence permit. Living over 90 days. Never had a residence permit.
Is it because they still in mine? That's what they
I don't know. I think it's just a reason that. Because if you went 6:15, it was also not today. The website said call me 478 if you want to get it.
It came out again? I didn't know it was out again.
Call me 478 if you want to get it. But it came 3:30, which is 4:30, an hour ahead, and I think it's still late.
Oh, it's watching.
Because you watch one, they live all the same.
Yeah, 3:30, I'm still lined up, 20:30.
We were there for this. Did we discuss the page circuit?
she's like,
Who is this detail?
I like
The page circuit.
Who's
I just don't know what we discussed.
it's true. It's like you get the wire.
It has to do with we didn't go into it's like a whole loop. Right? Like hippocampus and all that stuff. Mammillary body. Okay.
Oh, the silent
Yeah, there's a siren. Put your head between your head and your head between your legs and
I love that.
it used to be that sirens in Israel were like wheels. This is going up and down, right? And they didn't do it. This is like would have been like 10 years ago. This has been a real siren. And nowadays they just to sort of practice or whatever why they do it. But anyway, everyone like my age and higher would I like lost a heartbeat for a second there, because this used to be like a real thing. I remember the first Gulf War was. Yep. You don't hear that in the States, right? Although in other places there are siren systems in the States, or used to be at least. California and I don't know where else.
I was in Washington Heights for 4 years. There was a lot of sirens. It was all
A lot of sirens were open in the days.
At the beginning of the first Gulf War, this is 1990, I was in the army, and when the first siren went on, we thought we were attacked by chemical gas, you know, and so we all put our gas mask and everything. It was really stressful, but no, nothing happened, as you know. Okay, so. Good. All right. So we're moving on, and we discussed this a bit yesterday about the autonomic nervous system. Mostly we're talking about the sympathetic front. Just to remind you, most of parasympathetic innervations originate with the vagus nerve. It's a cranial nerve. It doesn't go to the spinal cord. But also, this parasympathetic innervation has a motor component and a sensory component. Exactly what you would find in the sympathetic innervation. The only difference is that it comes directly from the brain and not through the spinal cord, unlike the sympathetic innervation. So, for example, the motor innervation of the heart, the parasympathetic will make the heart beat slower. Sympathetic innervation makes the heart beat faster. And it's the other way around in the gastrointestinal tract. So parasympathetic will make the stomach and the entire tract really contract and move food, and the sympathetic innervation will stop that. This is why you shouldn't eat before you go running or doing physical exercise, for example. Because if there's food lodged within the GI tract, basically in the stomach, and you stop the movement of the stomach, you can throw up. What about the sensory output? So as I said, both these systems have sensory innervation. Usually, parasympathetic innervation, sensory innervation, is unconscious innervation. For example, how fast the heart is beating. And mostly sympathetic innervation is conscious innervation, for example, when something is painful. And this is important because the sensory information that goes in follows exactly the same path as the regular somatic innervation through the dorsal root ganglion and going into the spinal cord. And because the pain modulation and regulation in our spinal cord sometimes, most of the times, the body, it confuses the body. So pain from the heart, for example, will also manifest as a pain to the entire left upper side. Because the same nerves, the same level of nerves are entering the spinal cord at the same level. So T1 to T4, that's the innervation. But mostly, by the way, T1, T2, that's the sympathetic innervation of the heart, both motor and sensory. But also the upper thorax is also T1 to T4. So you're going to feel pain there. Another example for that, if you have gallstones, in case of gallstones, the infection, or it doesn't have to be an infection, but the blockage of the I don't know if you learned about this, but what happens when there's a gallstone, it sits in the common bile duct, and then bile will not come out of the, and eventually what happens is the gallbladder will get bigger. And the way it is, it will irritate the diaphragm. Okay? By growing, it will irritate the diaphragm. And by doing so, you feel pain at the origin of the diaphragm. The sensory innervation of the diaphragm, which is exactly the same as the motor innervation, is 3, 4, 5. So you feel pain in your shoulder blades, usually on the right side. So it's like a classical sign. Somebody complains of pain in the upper right part of the abdomen and in the shoulders, that's gallstones. Or liver cancer, but usually it's gallstones before liver cancer. And it's the same for appendicitis. At the beginning of the inflammation, it's a dull, generalized pain, because it's just sympathetic innervation, which is less, but just by sheer numbers, there's less neurons going into the abdominal organs than to our somatic part, to our skin. So it's, at the beginning, it's just sympathetic innervation. There's a dull pain. As the appendix will get more and more inflamed and more larger and larger, eventually it will touch the peritoneum of the abdominal wall. And once it touches the peritoneum, which is somatically innervated, the parietal peritoneum, somatically innervated like the abdominal wall, then the pain is focused and sharp. And if there's a burst appendix, the contents of the inflammation went out into the peritoneal cavity, and you don't feel pain anymore because it doesn't touch the peritoneal wall, the abdominal wall. Okay, but basically it's the same innervation. The dorsal ganglion, if you pain, if you stretch, things like that. Another example, by the way, is when you drink something hot, feel it going down the throat, but it's or cold somewhere around the abdomen, you don't feel it anymore. It's not because the temperature changed, it's because you don't have receptor for temperature at the lower part of the stomach. You just can feel it. Okay, so although it's a visceral sensation, it's the same concept. Generally, when you talk about sensory information, there are a few subdivisions. First of all, it's conscious and non-conscious. If you're talking about non-conscious, you can either have proprioception, which is the knowledge of where we are in space, or how much stretch is throughout the different muscles of the body, how contracted, how relaxed they are. This is true for skeletal muscles and for smooth muscles, of course. And interoception, which is our inner organs. So muscles, smooth muscles, but also secretion from how much we secrete from certain glands, for example. Or what we are absorbing right now, because as you absorb, as you digest throughout the GI tract, of course, there are different enzymes that you release. It needs to be timed. This is done by hormones, and it is done by the autonomic nervous system. Conscious sensory information is also, of course, subdivided. Into exteroception, which is the outside body, okay, like the sensation from the skin. And another type of proprioception that we are aware of, or can be aware of, okay? So let's go over the different systems. The major ascending system, the dorsal column and medial meniscus. This will move information that has to do with proprioception, touch, vibration over the skin. Okay, so it depends where we're at. It can either go to the gracile fasciculus or the cuneate fasciculus, where we are at the level of the body. And what happens, it would go, so this is important. So there's a corpule somewhere here that would, that's the, let's say, a pressure receptor, okay, that feels touch. And then the neuron itself sits in the dorsal root ganglion. It will go into the spinal cord. It doesn't synapse there. The entire thing goes upward. The fiber goes upward. If we're in the lower part of the body, it goes to the gracile nucleus, which we saw at the lower part of the medulla, the posterior and lower part of the medulla. And here it will synapse. And that's the first synapse we'll see. It will then go up towards the thalamus and decussate along the way. And that's the medial, and we can see part of these fibers, the fibers that go up to the medial meniscus. And I'll show it to you in a few slides. So it goes into the thalamus, synapse again, and then goes to the post-central cortex or the somatosensory cortex. So unlike the motor system, this has 3 neurons, 2 synapses. Okay, we just discussed this, but of course, as I mentioned, there's a certain order to the fibers that go up, and depending where the damage is, you can know what function would be affected. And if you do a cross section at the midbrain, okay, it's the same picture basically, almost the same picture. You see the medial meniscus system. You see the medial meniscus system here. Okay? These fibers already decussated. There's not one point that they decussate. They go like this, and along the way between the medulla and the midbrain, somewhere along the way they decussate. Okay? So if we look again at this picture, actually you can see the descending pathway. The cortical. This is the corticospinal tract here and here, and only this area is descending. This area is descending. This is ascending pathway, and also over here. Okay. And this is the medial meniscus. Important aspect of this system is the proprioception part of it. And I don't know if you learned about Romberg test. So Romberg test is what you do basically when you're drunk. You know, they ask you to stand up, close your eyes, and touch the tip of your finger. In order to sort of arrange ourselves spatially, we need 3 senses. We need proprioception, we need vision, and we need balance. Okay? We can work, if one of these systems is not working, this system not working, you will be okay. You can still have the right spatial sense. Okay? What they do in a Romberg test is you shut down one of the systems, like by closing your eyes. Okay? And then if this person has a problem, either he's intoxicated or there's a problem in the proprioception system, you would fail the test. Actually, it's called a positive Romberg effect, but it doesn't matter. You lose your sense of spatial awareness. So it would look something like this. Okay? So she's closing her eyes, and you have to be very careful because if the Romberg test is positive, she's going to lose. See? She's going to fall in a minute. He's going to catch her, hopefully. She can't keep standing upright. Okay? So what happens is she might have a problem in somewhere along the proprioception system. And this only happens when you shut down two of the systems. One isn't working because something wrong with the proprioception system. And the other part is that you close your eyes. Because just the sense of balance is still there. And it's not enough to keep us. If it was a problem with the cerebellum, for example, we can have all systems working and still we can't coordinate movements. So anyway, you won't be able to keep balance or do this, okay? Because the modulation of the movement isn't working properly. But when you do it to somebody who's intoxicated, of course, then the proprioception, or I think it's the proprioception system that doesn't work well, and of course certain diseases will do that. Also things like vitamin B, one of the B groups deficiency would also causes proprioception problems. There's a number of diseases, conditions that can cause that. The other system is the anterolateral system. It is also a sensory system that goes up. But this one will move sense of pain and temperature. This will cross on the same level as it entered. Same level it entered the spinal cord. There's a synapse here. Okay, there's a synapse here. After the synapse, the postsynaptic part will move to the other side. Will cross decussate to the other side, goes up into the thalamus and to the sensory cortex. So again, there are 3 neurons, 2 synapses, but the decussation is at the same level, of the same segment of spinal cord. Where would we see it? Where would we see it? In the midbrain. It's the ventral. You see the ventral spinal thalamic tract. And to a lesser extent, you can also see there's a ventral and a lateral spinal thalamic tract. Together, it's the interolateral system. Yeah.
So if say you have a damage at the spinal cord, and it was like the crude pain touch,
Yeah.
would you have the loss of crude pain, like if it was only like half
So,
the spinal cord was
It's the next 2 slides. I'll
Okay.
answer this, okay? Because it's an important question. Because so again, like we saw before, we know exactly it's called a somatotopic representation. We know which part is doing what. And there's a subdivision, of course, this could be touch, for example, temperature and pain. Okay. So in some diseases that the pain is always there. It's not acute, it's chronic pain. Now I'm not talking about regular chronic pain. I'm talking, for example, cancer patients who can't, the drugs don't work anymore, and they have like 6 months to live. There's no point of doing, something very. You need to manage the pain, so we can actually go and destroy that part that produces the pain. Okay, you go into the spinal cord and you destroy that. Chordotomy. So you don't lose complete sensation. If it's they do it very slowly. It takes time. They do it. They deliberately destroy just this part, but then you lose sensation of pain. Although within a few months it returns. I don't know how. I mean, it's not that just I don't know how. Suppose you destroy the pain neurons, pain shouldn't be there anymore, but probably there's a bypass somewhere along the way within the spinal cord. The pain bridges over. And eventually the pain will come back. But this is, of course, a very drastic measure, only very chronically ill. I don't know if it's always people who are going to die. It might be other types of chronic pain, but very severe that is not treatable by drugs. Yeah, they you know, it's a, you can, of course, once you destroy these neurons, they won't grow back. Eventually, within a few months, 6 months, a year, the pain will return, but that area is damaged, of course. So does that answer your question?
No, I was
Okay.
actually going to ask, so like if you damage half of your spinal cord,
Mhm.
like say it's the right side,
Yeah.
if the fine touch crosses over in the medulla, but
Yeah.
the crude pain crosses over there,
Yeah.
would you lose sensation, like the fine touch sensation from one half of your
Yeah,
body and
yeah.
the crude touch on the other half of your body?
It might be, yeah. Depends where they cross, and some of the nerves will go up, some of the nerves, go up in the same side, so they won't be damaged. The ones that cross on that side won't be damaged. Yeah. You have all these weird outcomes of spinal cord injuries. Okay, so this is of course very, very important. Other ascending pathways, for example, are the spinal reticular, which we actually sort of discussed. This is an important one. As we mentioned, the reticular formation can prevent information from going up to the cortex or descending information, movement. And as I mentioned, this is during sleep, for example. When you dream that you run after something and you don't really run because the reticular formation prevents motor information from moving downward, but also the fact that some people can sleep in a noisy room and some other can has to do with the reticular formation. Whether we allow, the reticular formation allows this information to descend, to ascend actually, to the cortex and wake you up. It's not exactly cortex, but it's more the thalamus to wake you up. Some people you lightly touch and they would wake up. Some other people you need to like shake to wake them up. It all has to do with, everything has to do with the reticular formation. And it's actually a learning system. So let's say you move into a new place and there's a dog next door that keeps barking. At the beginning you can't sleep with the noise of the barking, and eventually you learn to sleep with it. That's the reticular formation. And that's the spinal reticular tract. Same goes for light, same goes for a lot of other systems. Okay, so this is another important sort of behavioral ascending tract that is there all the time. This is why they say, that babies should learn to sleep in a noisy room and things like that. It's bullshit. Babies should sleep in the dark and quietly. But that's what they say. And finally, or almost finally, we're talking about the spinocerebellar tract. Two main types of tract that ascend to the cerebellum. Almost done, guys. Most of the tracks, most of the information, especially the posterior and the cuneo-cerebellar tracts. This is what we're looking at here. This is the dorsal spinocerebellar tract. This will go up. It's mostly muscle spindles, unconscious proprioception, things like that, that goes into the cerebellum, and it goes up, ascends on the same side. It doesn't decussate, and it enters the cerebellum through the inferior cerebellar peduncle. Usually it will not decussate, and there will be one synapse along the way. Okay, so it goes, it comes out here. Let's say we're looking at this again. Again, we have a neuron at the dorsal root ganglion, a synapse within the spinal cord, and then it ascend on the same side and going into the cerebellum. Okay. The other tract, which we see here, and that's the ventral spinocerebellar tract, decussates at the level of the spinal cord. Okay? It will decussate at the level of the spinal cord. It will go up into basically the upper part of the pons or even the midbrain. And then it will descend through the superior cerebellar peduncle, crossing over again to the other side. So it crosses over twice. This is from the ventral spinocerebellar. Before we talked about the dorsal, and this is the ventral spinocerebellar. It's this one over here. It's numbered by, it's not numbered here. Okay, I'm talking about this one. It crosses over once. There's also a synapse here, of course. So it crosses over once, goes up into the upper pons or even midbrain, and descends down through the superior cerebellar peduncle into the cerebellum, but crosses over again. So it crosses over twice. It decussates twice. So eventually it is also on the same side. So it is also an ipsilateral system. The dorsal spinocerebellum doesn't decussate at all. The ventral decussates twice. So both of them are on the same side. Here there is both systems are doing the same function. So there's no separation between this kind of proprioception or this kind of spindles that go to there. It's all intermixed. It's just two systems. Okay? All right. So last, is there a few other tracks that we don't know a lot about? In humans, they are very not well developed. But by the way that you can go over the fibers, you can sort of tell what they're doing. For example, the spinal tector has to do with the attention. When you touch something and you move your head to the direction. But it's very minute and we don't know a lot of. Okay. So we can move on to that's about for the pathways. We can start the arteries or blood vessels, or we can take a break, whatever you want. It seems like we need a break. Okay, we'll take a break, and then we'll continue with the arteries. Okay.
When are we starting the?
Take 15 minutes. It's fine? 15 minutes? Yeah. Yeah.
So, are we responsible?
No. It just goes to show that there is a lot of processing that is done within the amygdala.
Yeah,
And a lot of systemic effect. It's just this one.
just understand this.
Yeah, that the amygdala affects a lot of systems with the same, the output is the same, but to each system it does something else. I would not ask something like, okay, what is the amygdala doing to the parasympathetic system? But just to understand that, for example, a facial expression to fear can be done by the fact that the amygdala can affect the facial nerve, facial motor. Okay, things like that, but not specifically.
But not general, like the hippocampus and amygdala, just knowing that it deals with like emotion and memory.
Yeah.
Like that kind of detail, or a little bit?
A little bit more, because so it does that through different systems of the body.
Mm-hmm.
So it can affect, it does, motor neurons, it can affect the hypothalamus and thirst feeling and things like that.
Okay.
Okay?
Thanks.
I like this one. So is that the limbic system? No, I heard it asking a question on the limbic system that no one understands. Yeah, it's not even the limbic system.
Actually, the circuitry is well known, but exactly how it works,
It goes between the hippocampus and the amygdala.
and then that's what happens, and then it affects other outside systems.
How they figure this out? Like, oh yeah, this part's memories. Yeah, it's crazy. What? Memories?
They just took things out. So I know what happened.
No, I mean it's hundreds of years. It's just when they first thought that they're like, okay, this is like this part of the brain is memories. This part of it, people must have thought people were magicians. Like, so because there's no you look at a brain, look at this, and just a brain. Like there's nothing telling you. You know, you look at a stomach or a heart or this or that, and like it's pretty intuitive, like where it's going, what it's doing. But a brain, it's all theory. It's all like it's all you don't see it. They're just you don't see any of that. How they first figured stuff out was they would just like they did open brain stuff. And they would hit something and see like and the guy would go like this. You ever seen those videos? No, it's nuts. Yeah. The crazier thing is that a lot of those things are done like because they can anesthetize the area so you can be awake. Like some brain surgery stuff, you can be awake for it.
Your own brain surgery?
Be awake. Not your brain. What? Yeah. From I'm a big disciple of Calvin. I just watch everything, and then I think I'm done, and then just
And do
Come on, I don't do anything else.
speed it up.
there's like, you don't have to do any more than that, even it's just like, yeah, I'm like gonna try to get more of that.
They're too long though for a quiz.
They're free tests? Yeah.
What's going on? They're too, the class things are too long for, like, they're like each question's like half hour.
Lecture special
For this? Oh, we're learning else for
It's also hard when they divide it by chapter too. Okay, so that I can do, as long as it's not all jumbled. If they're short, then maybe, but if they're long.
I think
The recess question they usually
you don't need it now. You don't need it for like a few weeks, no? This material's on, what's it on? This material's not.
That's the longest one.
So like you don't need it right now.
For quizzes, I don't really usually do questions.
They're not? Yeah.
Yeah, for the quizzes, I usually do, I just do the content, I have for the, I don't really do the questions, I save the questions for like.
You've been at,
I'm sure.
I don't know.
I'd rather, I just try and learn the material content, maybe it doesn't need that.
first one, not that choice. I would definitely go for it. If it was right now,
Lost content,
I can't show.
Yeah, can't go on days, can't win them all. Can't win them all. No, I don't see it that way.
Oh, it's like really
No, there's actually.
I don't care. I'm just more just like.
Let's finish here on the fact that we have on theory, I think
Yeah,
it's
it's
really
like college. It's like.
It's had from your dad, right?
Yeah.
I think it's more of a hassle.
That's gonna be,
It's not even the money, it's just, it is real, they don't just do it's the season, it's the kind of art.
half of them are relevant and half of them are also outside of what we did. I did the first section. No, like half of them were like, were from the, and some of them were
It's safe. It's not designated, I mean, it's not like, I don't want to designate apartments. It's a lot. Put it in motorcycles don't
I'm just
have-
going on the slides.
How about this? How about those huge bars that have functions like this thing, runs across, they block up the motorcycle.
And then for the
Anything
self
over
driving
that.
chalk it up.
Serious,
Did you watch those, self?
Another really helpful with business methodology is three business that I got from it's not what you hear. So,
For what, do you ever ask the question?
I got a like and we got a mission of like, I think it's also for review and sort of policy. So I watched it. Yeah, I watched it.
And
So
then,
like, you talk about the show, you two way my speed,
hey, shit, I feel bad now, it should happen again, and then it happened again, I need to say.
and like I thought, but
I said, I'm trying not to let that
I
happen.
think yes, how
Again, but I mean, the truth is, I was actually
Yeah.
into it, there wasn't really a choice. Remember that whole situation was
And like I did all this
if we moved it, what did you move it? So rather just have it.
I was just thinking maybe I'll look at some of those.
That time because it was just so good. Otherwise, it's like 2 tests back to back.
I want that one.
Yeah.
I just like
That's a move.
What are you doing this week?
Well, I did the film and then I did the webcam. There was a couple of things on the webcam that I wasn't familiar with, and then I learned it because I saw it a couple times in the webcam. It was a similar concept, but a lot of stuff. I don't know if you watched it. You did.
I read it. I didn't.
The videos kind of more.
That's how they're on the book.
No, for sure.
Like I read the book and I'm like, okay, watching the videos, they explain what it. Basically, it's a audio book.
Yeah, like my first thing is always books, not videos. I usually use like 3 or 4 systems. So they make it easier.
I'm actually the opposite a lot. I usually watch the video first and then
I don't like to. I feel like watching to be.
no, I read a lot. I like to read, but I find that a lot of times I'll read something, won't make any head sales of it. If I watch it first and then I read it, then like.
So there are times that like.
But that's just different
So
things.
there are times that I was talking in the meeting and shit, like,
Right, when you read something, you're just like, what is this talking about?
the very opposite meeting.
Maybe storage.
I still like.
Right, Khan Academy.
Just different, what?
Like any like Khan Academy, just like those holes in
Yeah,
it.
yeah, it's all the same though. I don't know. I just feel like music and like I process it better. It's interesting.
I read shit. I do both.
It's annoying because I read slower than I listen to videos. But that's really weird.
I'd like to do a little bit of both.
It always happens.
You know,
Sometimes a couple of them even open
most
one
of the
sentence.
videos I just have it just happens to not be negative. Like I started making videos like this year.
iPhone.
I never use. I don't think I've ever used videos like a
It's hard. And when you delete it, by the way, you don't just delete it, you have to go to like the deleted section.
That's when I realized I wasn't good at math.
Section.
I bet it's when you're out of it.
I don't think I've ever watched like a video for a class. The point is here, I never used it. This year it was like 2 hours.
It goes into a
Right?
right?
I'll put it on the file, it's all text.
And it's not being deleted until you leave it.
Like whatever I say,
Well, listen,
slides.
Yeah.
Right now, press delete, it doesn't delete.
I never used to watch it.
I've never watched a video of anything this year. I think I watched almost every kind of video on the drive.
There's one more neural lecture after this.
And then you go read it.
The whole,
But I liked it.
Yeah, it's all right.
I wanted to like it, but I tried it.
I suppose we're done.
It didn't have.
so why do you just like,
Slide when they're available.
also know that.
Why the public doesn't
Can't really go to the new way.
Yeah, but like they could split it out better. Like in the first lab, it's like, yeah, we're pretty much covering everything we have to know now. And the second lab, we just reviewed what we did in the first lab.
So that was good. Basically, the second one was the first lab.
Yeah, exactly.
Yeah, they gave me your credit first. And so everyone said, like, the one that's is.
Good job.
That's a hard match.
On top of it, I got some friends with yes.
Now just do like legal.
And they've been two gaps in my
Yeah. You see? So it's not really deleted.
And then over time, that to get enough class, that just didn't really. I just list this. What do you mean on that class? You need stats and another map.
Why?
Like the fact that you said also like none of it you can because
Good, you get it.
So why you? worse would be why they give you that same crap.
It would have ended up feeling like all the requirements paying, so the police have to for other programs. So, no, so the problem is, everything was graduated.
Medical school figures it out.
And everything was graduated, the problem is that the
Fine. We have to finish one or something else we finish with one. Okay. See the course is like years.
We have 3 exams.
Yeah. Tomorrow and Thursday or just all Thursday?
So my choice was.
I just don't feel that it's not fair to you guys. I'm not offended at it, it's just not fair for you.
General biology.
And there's no reason to do that.
I agree.
Once a month is big. There's a lot of like stuff going on.
What do you have on pathology? What's the material for this quiz?
Intro stuff. Cell death,
Death.
injury, inflammation.
Wound healing.
Oh, that's relevant to the brain.
But it's just part of the course, right? It's not the entire, or it's not the final.
It's the first half.
It's general pathology.
Yeah, no diseases, nothing. It's very.
So basic histology, basically, or
It's histology, yeah. With some cell bio thrown in.
yeah. Okay. It's, in pharmacology.
Pharma,
Genetics, pharmacodynamics, and then the autonomic nervous system.
Okay. So
it all weaves together.
hopefully. As I told you that usually you don't treat a system of the body, there's an entire patient attached to it. So. And I remember I did a biology, I was a biology major, and I remember hearing like dozens of lectures about how we're going to cure cancer. And I particularly remember one that says, this does, it was an amazing drug that killed only cancerous cells and left normal cells fine. There was one little drawback that it lowered the pH of the body to around 3. So that didn't help much.
Can't get that far. He said,
Yeah, no, it's fine.
Okay.
Yeah.
Awesome.
So last lecture, I'll try to keep it simple and just the important part, and we can all study for your exam, and I don't know what I'm going to do. So we're going to talk about blood vessels. And this is related, of course, to the meninges itself. I don't know if you talked about this, but the big, for example, the big venous drainage out of the brain is done through the dura. The dura is actually a double layer, and at a certain point, that these two layers detach from each other, and the cavity that forms is a blood vessel. Okay, there is no blood vessel within that cavity. This is where the venous blood would flow out of the brain. Okay, and so there are some other blood vessels that you can see within the dura itself that supply the dura itself. And has nothing to do with brain blood flow. But this is, of course, very, very important to the function of the brain. Most of blood flow to the dura, basically the dura, is done to the middle meningeal artery. It's very important. The middle meningeal artery is a branch of the maxillary artery. It comes off the external carotid. Again, nothing to do with the brain. But you can see it over here. Okay, this is another branch of it. You can see it over here. Sometimes side impacts, a car accident, or any kind of injury to the side of the head. The skull is very, very thin here. Okay, the temple area. And since the skull is relatively thin, if it breaks, it can cut a little meningeal artery. And that can cause a hematoma, usually epidural hematoma. And again, the main problem here is that the brain has nowhere to go. It's within a closed box, the endocrinium. And as blood accumulates within the endocrinium, the brain will slowly or not slowly will sort of be crushed by the blood, the volume of the blood. And that's of course problematic. We need to drain this blood immediately. Okay, so if we look at a cross section, this is a coronal section of the top of the skull, basically. So you see the scalp, you see the skull, you see the brain itself, you see the pia, arachnoid, and dura. And as I said, usually the dura, it's a double layer sort of ligament or tissue. At a certain area, these two layers detach, like here. You have this cavity, and this is where most of the brain blood outflow will go.
Can you point out the arachnoid again?
Sorry?
Can you point out the arachnoid?
The arachnoid is the red. And you see, it's called arachnoid because it looks like a spider web. And you see all these are blood vessels, actually, small blood vessels. And if you remember in lab when we detached the arachnoid, you could have seen it actually, but it's very, very, there's a lot of blood vessels. Yeah, sure.
What's the gallia aponeurotica?
It had nothing to do with us. Gallia aponeurotica, it's part of the scalp. I don't know if we discussed this in anatomy, but you probably saw that the scalp itself is actually it's almost as thick as the skull itself, and by itself, it's very condensed. So if you get an injury to the head somewhere, even a minor injury, you get this bulge of blood accumulation, like it's a hematoma, but it's not within the scalp. It's actually between the skull and the scalp. And the gallia aponeurotica is this white fiber here. Okay, so you can move the entire skull by itself, and it's not really attached to the bone, to the skull. Okay, but since it's so dense, usually blood tends to accumulate between the skull and just. Okay, so if we know the different, and this is important, of course, for the rest of the talk, if we know about the different layers of the meninges, we can talk about the spaces. We discussed discussed within the spinal cord, we discussed the epidural space, but also there's a potential in the brain. There's a potential epidural space between the skull and the dura. There is a subdural space, which is also a potential space. Usually, the arachnoid will touch the dura. And the subarachnoid space is the space between the arachnoid and the pia, and this is where we have the CSF. So it is a real space. The brain floats between the arachnoid and the dura and the pia.
Sorry,
Yeah.
what's the space called when the two layers of the dura separate? Like
Well, it's called a sinus.
Okay.
We're going to name it specifically, but it is called a sinus. A sinus basically means a cavity. And with this we saw in lab the difference between here the right hemisphere is with the arachnoid, and the upper part, or the left hemisphere, is without the arachnoid. And I just want you to note the blood vessels. Usually blood vessels that you see on the arachnoid are veins. The arteries are deeper, and usually you don't see them. You see very small, fine, again, blood vessels. And another thing I want you to note is all these pits, not pits, but sort of leaflets here. This is called the arachnoid granulations. We talk about this. So arachnoid granulation is something you see on the top of the brain. It's part of the arachnoid. This is where CSF will be absorbed or moved from the subarachnoid space into the blood vessels, into the venous drainage system. And with age, you'll see more and more of it, and it's fine. Sometimes it becomes so big you can actually see pits on skulls, the inside of the skull. You see like all these pits, and you know this person was old because he had a lot of arachnoid granulations. So it's not a disease, this is fine, and we all have it. Another thing we saw in lab, and it's also important, not so much to blood flow, but to the movement of CSF, is the cisterns. Okay, this is where CSF leaves, the fourth ventricle. Down here, we have a big cistern, a big cavity or a gap between the arachnoid and the pia, where CSF accumulates and then slowly drifts out through hydrostatic pressure, leaves the ventricles and the cisterns. So the biggest one is down here, the cisterna magna or cerebellomedullary cistern. But we have some other cisterns, for example, the superior cistern, interpeduncular cistern, and pontine cistern. They are all smaller and less important. But again, accumulation of CSF. Okay. So let's discuss within this context. Let's discuss the blood vessels themselves. We start with the arteries and then the veins. So actually, only 4 arteries go into the brain. In the front, it's the 2 internal carotids, which are the most prominent and much larger than the 2 posterior ones, which are the vertebral arteries. The internal carotid is, of course, a branch from the common carotid. The vertebral artery is a branch of the subclavian artery. Within the cervical, all cervical vertebra at the side in the transverse process, there's a hole, gap in which the vertebral artery goes to. It goes up, and over C1, it will go in the hole and then turns medially and enters through the foramen magnum, enters the cranial cavity through the foramen magnum, which is what we have over here. Okay?
Can you explain one more time?
Yeah. So the vertebra is going up within the vertebra. Okay. Once it passes C1, the first vertebra, cervical vertebra, it goes like this, medially. Okay, it actually, if you look at C1, you see just medial to the hole, to the vertebral canal. See, it's like smooth. This is where the artery sits, like it goes like this, and so it goes medially and actually through the foramen magnum into the endocranial cavity. Okay. Okay, so this is a general drawing. We have the internal carotid on one side and the vertebral on the other side. And these four arteries are interconnected to form the actual blood circle supply, or the circle of Willis. I told some people in lab, Willis was a British physician who was one time he dissected, he was in med school, dissected a woman who was hanged, and she woke up in the middle of dissection. And she was fine. I mean, they didn't kill her or anything. And she went on living for many, many years. I wonder if that affected his medical career or not. So, let's follow the path. I know we did it in lab. Let's do it one more time. So we have the two vertebral arteries converging to be the basilar artery, forming the basilar artery. And then separate again here and here to give the posterior cerebral artery. The posterior cerebral artery. The posterior cerebral artery gives off two posterior communicating artery which enter the internal carotid. The internal carotid splits into two. Branches go laterally, disappear to the sides, are named the middle cerebral artery. And branches that go forward or anteriorly are the anterior cerebral arteries. The anterior cerebral arteries are interconnected. Sometimes they just join together. There's no blood vessels in between them. They just join together. Sometimes they run parallel, and then, like in the joint, something bridging them. And this is called the anterior communicating artery. And that closes the circle. So, in theory, you have, if one of the big blood vessels are it's closed or crowded or whatever, blocked, there should be enough blood supply from the other arteries. But this is, of course, you saw these arteries in lab. They're very small. The communicating arteries are very, very small. They can't supply the amount of blood that is missing from one of the big arteries. It would only work for a few minutes. Not more than that. It's not functional. It's not, at least in humans, it's not working. Plus, depends which book you're reading. About 30% of people, in 30% of people, the circle is not complete. Usually, one of the posterior communicating is missing. And again, usually it's meaningless. I know that it's meaningless because I see these brains, and these people live to old age, and they're all fine. Okay, so this is the circle, but of course with each, there are many other more arteries that we need to go over. This is just a basic circle. You can see it over here also. So, of course, it looks much more complicated when you have it in the entire brain, but if you look closely, it's basically the same. Two vertebral arteries, no one is missing, but the vertebral artery, basilar, posterior cerebral, you can see the posterior communicating. The cut is, it's written down, cut end of internal carotid over there where the posterior is going to, and you can barely see the anterior cerebral here. A bit here and a bit here. Okay? The anterior cerebral artery, and you can also see it in the section that I made here a few, I don't know, this is a few years ago. Okay, again, basilar, posterior cerebral communicating, and this is the anterior communicating. The posterior communicating, and this is over here, the anterior communicating and anterior cerebral. Let's look closely at other blood vessels and name them and the part that they supply. So out of the vertebral arteries, we have 2 or 3 blood vessels that we need to remember. First off is one medial blood vessel, the anterior spinal artery. And they also give, lower down, they give the posterior spinal artery. It goes in the front or the ventral part and the dorsal part of the spinal cord. These only supply, usually they would only supply the upper part of the spinal cord, the cervical part. And they give also the posterior inferior cerebellar artery, or the pica. It supplies the lower and the lower and frontal part or ventral part of the cerebellum. We see the convergence of the 2 vertebral arteries forming the basilar artery. Out of the basilar artery, we have several other set of arteries. The ICA, or anterior inferior cerebellar artery. The pontine artery, which are not written down here, but all these small arteries are called altogether pontine arteries, supplies the pons and the rest of the upper part of the brainstem. And the superior cerebellar artery. I mentioned this before, usually it's from the anterior inferior, sometimes it's from the superior cerebellar. There's one small branch, the labyrinthine artery. It's very small but very important. Because if the labyrinthine artery is blocked, there's no blood supply to the inner ear, because it's one of 2 blood vessels that doesn't anastomose with any other blood vessel. And so that's important, and it happens. It does get blocked, for example, in diabetes. Same is true for the ophthalmic artery, or a branch of the ophthalmic artery, the central retinal artery, which is not anastomosing with any other blood vessel. So again, basilar will end these 2 blood vessels, the posterior cerebral artery. We'll see in a minute exactly what they supply, but basically, of course, the back of the head. the back of the brain, sorry. And let's look closely at what happens after that, the split of the basilar, okay? What happened in this area, I'm not talking about the anterior cerebral, just generally the area around, let's say, the pituitary, the interpeduncular area, a lot of small blood vessels that are divided into subgroups. So, for example, we have a posteromedial or posterolateral group. The importance of these small blood vessels is that they penetrate the surface of the brain and go deeper, for example, to the diencephalon area, to the subthalamic area, to the hypothalamic area. So you don't just see them on the surface, that penetrate the surface of the brain, goes inside to supply blood to the inner brain tissue. So out of the posterior cerebral artery, we have a posterolateral group and posteromedial group that supplies the area just around the posterior cerebral, the beginning of the posterior cerebral. Basically the mammillary bodies and part of the interpeduncular fossa. The posterior part of the interpeduncular fossa. Also note that this is classic, that between the posterior cerebral and the superior cerebellar, we have the oculomotor nerve. Okay, so between these two blood vessels, we have the oculomotor. And of course, aneurysm around this area over here, at the split of the basilar, can cause problems with eye movement and things like that that are associated with the oculomotor nerve. Okay, we see the posterior communicating artery here. Some blood vessels coming off it, very small blood vessels going into the pituitary area. And then we have the internal carotid or middle cerebral. The name changes. If you look at the picture for a sec, when does the name change from internal carotid to middle cerebral? Again, depends which book you're reading, but basically either when, okay, so this is the internal carotid going in, when it will give off here the anterior cerebral, after that the name will change to middle cerebral, or once the posterior communicating is going in, like here, this would be internal carotid, this would be middle cerebral. But out of this vessel, the middle cerebral, we have several arteries that are important. One of them is going all the way back, the anterior choroidal artery. These vessels will go into the ventricles and will form part of the system of the choroid plexus. Other small arteries that comes out of it are the lateral striate group, that we see over here. And again, all these small blood vessels penetrate the brain. For example, the lateral striate group goes into the base, to the caudate nucleus, to the lentiform, also the putamen and the globus pallidus. Very, very small, but there's a lot of them, and they go well deep into the brain. Medially, if this is the lateral stride group, medially you have the medial stride group, or artery, you see it over here. Okay, here and here. Okay, we see the anterior cerebral artery going above the optic nerve or optic chiasm. We see the anterior communicating artery over here. And the anterior cerebral artery by itself subdivides into 3 groups. Coming out of the internal carotid is the first group, and after the anterior communicating artery, we have the second group. And then once it goes over the corpus callosum, it will change to the next group, which is, well, the third group, or third part. And of course, along the way, it will give branches off to the different aspects of the cortex. We've got an orbital artery over the eye. You have got a frontopolar artery, colossal marginal. You don't need to remember this name. It's not important, but just remember it gives off artery, and we'll discuss in a minute where would it end.
That's the anterior cerebral.
These are all branches of the anterior cerebral. Now we're going to talk about branches of the middle cerebral. Now the middle cerebral goes laterally, sideways, into the lateral fissure between the frontal and temporal lobes. Okay, so it disappears within the brain, sort of. And it would supply more of the inner structures of the brain. So we have vessels coming from underneath. We have vessels coming from the side. So for example, if you look at this picture, this is the corona radiata. We talked about this. Some of the inner structure supplies from the lower parts. And some of them would be supplied from the middle cerebral artery. Okay? We're gonna go back to the middle in a minute to see exactly which part it supplies. But the posterior cerebral artery also subdivides into several parts. First part is before the posterior communicating. Second part is after the posterior communicating. And the third part is once it goes over the calcarine or parieto occipital, basically it's the parieto occipital sulcus. So we're looking now at the blood distribution out of these 3 vessels. So most of the medial or lateral aspect of the cortex is supplied by the middle cerebral artery. If you remember, it goes over the lateral fissure. We will see it again here. Usually it's not on the surface. It's deep within the lateral fissure. You need to pull it out to see it. It supplies most of this lateral aspect. So part of the frontal, parietal, and temporal lobes, even occipital lobe. So for example, most of Broca's area is supplied by the middle cerebral. The post-central are also supplied by the middle cerebral. This is the medial aspect, but you see very nicely that on the inner aspect, most of the frontal and part of the parietal lobes are supplied by the anterior cerebral, the posterior and temporal by the posterior cerebral, occipital lobe and temporal lobe by the posterior cerebral, and there's a tiny bit or small part where the uncus is parahippocampal gyrus, which is supplied by the middle cerebral. Okay, if we do a cross section, again we can see that the distribution of the blood supply. And again, a lot of the blood supply to the internal parts is coming from the lower blood vessels. All right. Moving on to venous blood drainage. Most of the arteries are coming from the bottom, and most of the vessels or the veins are on top. And we would see them on the arachnoid itself. So blood drains out from the brain, from the inside of the brain. And accumulates usually on the side, on the upper part, usually as it comes through what we see over here. Okay, this is the superficial middle cerebral vein. It goes over the lateral fissure. It drains most of the cortex. And this blood will flow eventually through anastomotic veins. This is the superior anastomotic vein, and there's an inferior anastomotic vein. These will drain into the sinuses of the brain. As I said, the sinuses, we're going to name them in a minute, the sinuses are just cavities of the dura. There's no like a blood vessels that run within that cavity. The cavity is the blood vessel. So it either drains up to the superior sagittal sinus, or it will drain down to the transverse sinus. Through the inferior anastomotic vein. Okay. So now we're talking about the sinuses that are within the dura. The biggest one is the superior sagittal sinus, which is on the top, okay, on the top of the endocranium. Okay, the whole thing over here. It's a very big vein. You can't just cut it open. And from it, actually, you have, if this is the dura coming over, okay, the dura, of course, will split, going like this instead of going over the endocranium. It goes like this and goes downward. Here, it forms the flux cerebri, okay, that separates between the two hemispheres. At the bottom of the flux cerebri, we have the inferior sagittal sinus, here. the inferior drains into a straight sinus, or this straight sinus, that is, it is in the midpoint between the falx cerebri and the tentorium. Okay, so inferior sagittal, straight sinus, meets with the superior sagittal sinus. And the point of here, the back point where they meet is the confluence of sinuses. Confluence will go sideways, laterally, as the transverse sinus. So the transverse would be between the occipital lobe and the cerebellum, okay, like this. Transverse sinus goes downward as a sagittal sinus. Sorry, sigmoid sinus. And sigmoid sinus exits the brain as the internal jugular vein. And eventually blood leaves the brain. Almost all blood that leaves the brain is through the jugular vein, the internal jugular vein. So this is the confluence of sinuses. This is the tentorium. Transverse sinus, sigmoid goes downward, and then internal jugular vein exits the endocranium. You can see that around the pituitary gland over here, there's a large network of small veins. This is the cavernous sinus.